My name is Dr. Wesdon McCann. I'm an optometrist in London, Ontario, Canada. I own 9 clinics here in Ontario and very much enjoy focusing on the disease aspect of eye care. So we're going to talk about unveiling novel structures, structural biomarkers in the diagnosis of management of glaucoma, as we have been so far, and we'll focus on a specific case here too. So we have a specific case here, 83-year-old white male. His RX is up there. His VA is entering, we're 2030, 2040. He's been managed as a glaucoma patient for many years. And this case is going to be talking about watching for progression and thinking about the entire eye as a whole, as opposed to just isolating specifically and narrowing having too narrow of a focus on glaucoma. So his Tmax pressures throughout my observation and management of him was 12 and 10. I had, like I said, inherited him already on treatment. Packs were there, and he was currently on Lumigan and Combigan to start. So we've got our Claris ultrawide images here, and we have to think about, again, these structural biomarkers, both in looking at the patient in our DDFE as well as in our retinal imaging, and through our other diagnostic tests like OCT and making sure we're observing that visual field change over time. So things to look out for, certainly that scleral ring, that neuroretinal rim, the RNFL, parapapillary atrophy that we'll see in this case, as well as any sort of disc hemorrhages that can occur. Now, I'll zoom in on the nerve here. It is a little blurry because, again, this is screenshotted and expanded. But when we look at the neuroretinal rim and the nerve itself, we're going to look at a few different components. So Michael had mentioned about how our normative database now expands into taking into consideration the size of the optic disc. So just thinking about that in your management and while you're going through your cases will be important. So in this case, again, it was a fairly average scleral ring, fairly average nerve size. So not to have to consider something different. Again, this case was done before we had the update to the Cirrus recently. Neuroretinal rim, here we can see there's certainly some thinning superior and inferiorly in the left eye and both in the right eye, but more so inferiorly there in the left or in the right eye as well. Parapapillary atrophy exists in both eyes, but again, take that consideration looking at that zone B, that zone beta for that parapapillary atrophy, and we didn't see any disc hemorrhages in this picture. When we look and zoom back out at the image, the patient had some mild cataracts, so difficult to see the contrast on the RNFL. Visually looking in terms of any sort of RNFL defects we can see visually, but there was nothing substantial that jumped out in the retinal photos. When we look at the visual field, we can see his baselines there. When I started management of him in 2015 and 2016, he was a fairly good field taker, which was great at 85, which is always appreciated. And you can see there was some progression noted on the visual field. So keep that in mind. The field progression we're noting is much more central than it is in that nasal step area, but there is certainly a nasal step that exists that you can see more evidently in the left eye than the right eye. When we look at more recent fields that he had, again, this darkening and deepening of this central defect that we see and notice in both the right eye and the left eye. But again, not really a consistent change with that nasal step turning into an arcuate defect. So paying attention to, again, what's progressing and why is it progressing and how is that contributing to the pathophysiological process of glaucoma, and is there a disease progression in glaucoma here? So there certainly is a visual field change. Again, looking 1 year later, 2020, still a darkening and deepening of that defect. Perhaps looks a little bit more deeper as a nasal step here and potentially an arcuate scotoma. But if you look up in the visual field up here, you can certainly see that defect is much more central as well. So again, central could be a progression of glaucoma, but what is causing that change will be important when we're looking at the biomarkers on our OCT. So when we look at the OCT changes, or the OCT in general, there's certainly an inferior thinning here and a superior thinning here in that left eye. And we're right down almost to the RNFL floor here with that superior defect in the left eye. So we've got to be cautious when we're watching our OCT for progression analysis that we're not paying so much attention to the OCT progression on RNFL in this superior range in that left eye, but we're also really paying attention to the visual field where we're going to see a lot more progression and change associated with more advanced glaucoma. Our T-SNP line is certainly asymmetric here, and you can see the RNFL defects inferiorly, superiorly, and inferiorly here in the left eye. When we look at the GCA analysis, you can see much more defect here superiorly. We certainly do have an inferior thinning that looks present as well. Same thing inferiorly here, much more than superiorly here in that right eye. And again, all very much match up with the RNFL defect that we see here on the pie chart. So when we're looking at form, and I really appreciate form in glaucoma workplace, I don't know how I'd practice without it now, managing glaucoma. But when we look at progression analysis on this progression analysis chart within glaucoma workplace, this one I'm specifically focusing on OCT so that you can see this rate of progression in that right eye and that left eye. But when we see this rate of progression, we're looking at the average ganglion cell change, our superior average RNFL thickness change, inferior here in our T-SNP line, and then mirrored here in the left eye. So we certainly see a GCL decrease here in that right eye. Fairly stable superior, fairly stable inferior. Again, GC, we see a decrease here in that left eye, but again, fairly stable superior RNFL thickness, fairly stable RNFL thickness inferiorly. Keep in mind, the superior one is already at the floor, so just be cautious in terms of when you're observing this data as to whether or not progression is truly showing on that visual field. When we look at the right eye and left eye here in terms of progression map, very minimal progression here, superior and inferiorly, but we definitely see this progression and change in the ganglion cell analysis here. So this is a red flag that there's certainly something happening, but we need to dive deeper to find out what progression is occurring and why is it not progressing as well in the RNFL change here. Same thing in that left eye. Left eye, there might be a little change here inferiorly, but it stayed fairly stable after this first little bit of change. And again, when we looked at that the ganglion cell change, we're seeing much more ganglion cell analysis change than we did RNFL change here in the progression map. So something's different, something isn't lining up. So make sure you're not too focused just on glaucoma and that you're looking at this as a bigger picture. So when we zoom out a little bit and look at it a bigger picture for this patient, as opposed to being so focused, looking at your retinal photos, looking at your OCT, we can see that, yes, this GCA certainly looks like it's progressing here, but if we look at the retinal photos, you can see there's a significant macular change that's occurring over time. And if you look on your B scan with your OCT, you can see significant geographic atrophy that's occurring here in a number of areas throughout the macula, and you can see it here on the infrared image as well. So this infrared image of geographic atrophy is starting to match up perfectly with our ganglion cell change that's occurring here as well. So be careful that we're really watching this as an entire eye and not just focused on glaucoma, and just specifically looking at any change could be an indication of glaucoma progression. When we're looking at the left eye, we're seeing exactly the same thing. GCA looks like it's progressing, but if you look carefully at your photos, you'll see significant geographic atrophy that's progressing in this patient over time, as well as you can see it on the infrared image and your B scan here. And his pressures were already 10 and 12, and significant change was occurring only on the GCA. So if you look at the visual field and you take a look and you flip that visual field from the functional structural analysis, you can see that inferior quadrant or that hemiquadrant that is being darkening, and that quadrant is getting much more deep in terms of its defect. If you flip it and match it, it's matching right up to the GCA change that's there, as well as the geographic atrophy change. So in summary, definitely looking at changes that are occurring, and these biomarkers are important, but we need to be vigilant and make sure that we're not making very hasty and fast decisions when managing glaucoma, and make sure that things are making sense. Look at your clinical exam from your dilated exam, as well as your retinal photos, as well as your OCT and your visual field, and make sure things are matching up and making sense. And we're watching for these ancillary diseases that can occur at the same time that may not be related to glaucoma, but could be creating changes in your progression analysis and your biomarkers that you're certainly utilizing for analyzing glaucoma. So use all those ancillary testing. Make sure you understand the disease stage that you're in, and you're using fields, OCTs, and photos appropriately in those different stages of the disease. Establish target pressure, I would say, but don't be careful maybe not to record it within your file as to what your target pressure is. Think of it more in your head and have a goal for one. Again, if you have a target pressure established in your file, you're not hitting that target pressure, despite all your management options and challenges that you can come across, that could come back on a medical legal challenge down the road if someone was to say you did never hit your target pressure. Monitor and adjust as you need necessary, and certainly zoom out every once in a while to see what are some of the bigger challenges that might be here and comorbidities that exist as well.